Hello everybody. It gives me immense pleasure today to present to you the results of this phase 3 long-awaited trial. You know, it's almost 4 years down to date when I was standing in the same forum, pressing Northwest Biotherapeutic, the sponsor, to finish the study, to unblind the data and analyze it and provide it to the brain tumor community. And here we are today. I want to say the results are well worth waiting for. But you know, when one is dealing with a malignant brain tumor, there is never a good reason to wait. So instead, I'm going to tell you how excited I am to have these results available. And hopefully, once you've seen the presentation, you'll be excited too. So let's start by a quick review of the background. So as you all know, glioblastomas are the most malignant primary brain tumor known to man. As a surgeon, they're very, very difficult to treat. Why? Because they're infiltrative. So surgery is never going to be the answer because we can never get every single cell out of the patient's brain. Also, they're extremely heterogeneous. So that means that no two glioblastomas are exactly the same. Even if you operated on the same glioblastoma in the same patient and sample two different areas, there are going to be differences. And therefore, those blanket adjuvant forms of therapy, like radiotherapy, like chemotherapy, are not ever going to give us the complete answer. And this is crystallized in the outcome of the present standard of care for these patients. So as you know, the standard of care that we practice today was established really in 2005 following the great work of Roger Stupp, where he showed that addition of temozolomide chemotherapy to surgery plus radiotherapy extended survival by about 2.5 months. So unfortunately, that means that even with what we have available today, the median survival of patients with glioblastoma is in the region of 15 to 17 months. And unfortunately, they do recur, and once they recur, most majority of patients don't survive longer than 8 months. And 5-year long-term survival is extremely rare in this patient population, less than 5%. But let me tell you, this is not because of lack of trying of the brain tumor clinicians and the community. This review summarizes the data, and as you can see, there have been well over 400 clinical trials looking at over 31,000 patients. But unfortunately, despite trying the whole range of treatment from checkpoint inhibitors to chemotherapy to CAR T cells, unfortunately, there has not been anything that has significantly so far changed the outcome of these patients since the great work of Roger Stupp. And perhaps the one trial that I remember vividly, because my team were involved in this, was the so-called ACT4 trial that looked very promising initially, but unfortunately, once we got to the phase 3 study, that failed to show the promises of the earlier studies. There have been a few positive signals, though, so it's not all doom and gloom. So for example, Roger Stupp and others published this paper recently looking at tumor treating fields, which is a local treatment for glioblastoma patients. And what they showed was that addition of TTF to maintenance chemotherapy improved the progression-free survival by around 2.7 months. So significant results, but of course there are certain stringent requirements. For example, patients need to wear the TTF device for at least 18 hours a day. And we know that this device can be a bit difficult to handle, especially if patients have poor mobility. So we do need to improve the design. And if the Optune company, the Novocure company is listening, please talk to us. We can tell you how we can do this treatment better and improve it for the patients. As you know, I work in the UK, and the NICE, which is a body advising the government on the efficacy and availability of the treatments, as early as 2007, approved the use of gliadel. So these are carmostin wafers that can be implanted inside the tumor during surgery to deliver the carmostin chemotherapy. And again, that was found to be beneficial for newly diagnosed glioblastoma, not recurrent, because the data had shown about 2.2 months survival advantage. But again, there were certain stringent requirements. So as a surgeon, you have to make sure that you remove at least 90% of the tumor. You have to make sure there is no breach into the ventricles, for example. You also have to do a very good dural closure to make sure there is no leakage of chemotherapy outside. So quite difficult treatment to actually deliver. And this is partly why this hasn't really taken up the way that we anticipated it would initially. So what does that mean? So that means that current landscape of glioblastoma management is actually quite limited. So no systemic treatment has been shown to extend survival now for about over 17 years. And when it gets to recurrent glioblastoma, it's even worse, very grim. For 27 years or more, we have not had anything that would improve the survival in this patient group. So this is where the excitement comes from, and this is where I hope I can show you the value of DCVax, the indexed drug that we are presenting to you today. So let's look at the overall overview of the trial. So this is a treatment based on autologous dendritic cell pulse with autologous tumor lysate, which is then injected or delivered to the patient through intradermal injections. So this was a double-blind randomized trial with crossover, and I'll come back to this latter point, the crossover element, shortly. And the initial primary endpoint was defined based on progression-free survival, but this was changed, revised to overall survival, and again, I'll come back why this had to happen. Very large trial, perhaps one of the largest of its kind, 331 patients recruited across 94 different sites in 4 different countries. It's a long trial time plan, so span started in 2007, and it was delayed a few times, most recently because of the COVID. The whole life, unfortunately, had to be stopped because of COVID for a couple of years. But that length of the study did allow us to get some extra learning, which we then fed back into improving the trial design. And again, I'll come back to that shortly. So how does it work then? So at surgery, so it's a surgical form of immunotherapy, if you like. So surgeon is essential. Why myself as a surgeon could be involved in this, for example. So the whole process starts by resecting the tumor, and once we have got the tissue available from the patient, this is then converted into a lysate. The next component of the therapy are the dendritic cells, which are obtained from the patient through a process called apheresis. And once the manufacturing has taken place, so combining the lysate with the dendritic cells, then the vaccine is injected through a series of intradermal injection. And the idea is that the dendritic cells, which are loaded or pulsed with the tumor antigens, will then present these to the T cells, which can then divide and hopefully attack the residual tumor. So this is how the principle of this therapy is based on. So in terms of study treatment and schedule, so as I mentioned, surgery is the first step. Then patients go on to have the leukapheresis, on average within 3 weeks of surgery. And then whilst they're having their chemoradiation phase, so the concomitant phase of H2 protocol treatment, that gives time to produce the vaccine. And once that's done, patients are randomized, and then depending on how many doses of vaccine available, there's a schedule of vaccination. So for example, the first 3 are given about 10 days apart, and then that interval gradually increases to a 6-month period, eventually depending on the number of dosages available. So let me go back to this topic of crossover design, because when the primary, if you like, interim analysis was published in 2018, there were questions, why did we have this crossover element within this design of this methods of this study? So let's just stand back and look back at this. So we live in a real world with real problems. So there are ample data available showing that a small minority of patients with brain tumor who are eligible for any kind of trial are actually entered into trial. So something like 10 or 15% of all brain tumor patients who could be in trial actually are enrolled into trials. And there are many barriers to this, and we have been working with various charities in the UK trying to understand the barriers to recruitment into trials. There are multiple, but one of these, especially for novel agents, is the fear that if you're in a trial and you get randomized to the placebo group, then you're not going to have the active compound. And patients don't want to enter in such a trial because they don't want to deprive themselves from being able to actually get the drug. So, we consider that if we have this crossover design, then at least there is the opportunity for the patients who progress, the tumors progress, to end up having the treatment with DCVax. This is particularly important when you have an interventional, if you like, trial like DCVax, where patients have to have invasive procedures, leukapheresis, to get the dendritic cells from the blood. And as you know, there can be complications. There can be thrombophlebitis. There can be thrombosis. So you're putting patients through a potentially procedure that could have side effects. Then we thought ethically it was also only right for the patients to eventually have the ability to receive the active compound. I also promised you to come back to this issue of progression-free survival versus overall survival. So when we first started this study, many, many years ago, the whole concept of pseudo-progression didn't even exist. So what does progression-free survival mean? It means a time from delivery of the a treatment or a compound to the patient until under scans there are changes that could suggest tumor progression. So now we know that many treatments that we provide to the patients with brain tumor could potentially have effects on the scan, so they can change the imaging. This is called pseudo-progression. So this means that, for example, you can see a change on the scan, but this is not because tumor is progressing, but this is the effect of treatment. This is much more pronounced now we know with immunotherapy. And this slide is from courtesy of Linda Liao, which has shown that in patients who receive this kind of immunotherapy, there are T cells which are, get involved within the tumor, and we can see that manifest on the scan by changing the scan appearance and the way the contrast enhancement changes. So essentially, this means that we cannot use progression-free survival to look at these patients because it's totally pointless. What you are seeing on the scan is not necessarily tumor changes. It could simply be the effect of treatment. So it could actually be a good thing rather than a bad thing. And clearly, it's been nonsense to use a biomarker of response when it is totally false from the outset. And based on this, we decided to change the endpoint from progression-free survival to overall survival. And actually what patients care about is how long they live with good quality of life, rather than how the scan looks, whether changes are caused by the treatment or otherwise. And just to make this clear, that change of endpoint from progression-free survival to overall survival was decided before the data was unblinded. So this was decided as part of change in methodology before we could have analyzed the data. So this has consequences. So once we have changed the essentially outcome from progression-free survival to overall survival, this means that we can no longer use the internal controls, if you like, because there was crossover, and essentially the vast majority of the patients received the compound. So we cannot use the internal control for assessment of overall survival. So what we did then use was a series of external controls to have a control population to compare our data. And this concept of using external control is not actually unique to this trial. And in fact, there has been a tendency recently in the community, in the neuro-oncology community, to look at external controls to maximize the benefits from trials. Look, we've been doing the classical versions of trials for many, many decades, and unfortunately, we have not been able to achieve the outcomes that they wished. So there is a need to change, and for example, in the UK, we've been quite proactive in using what we call adaptive trials. So I'm lucky enough to be involved in other trial called Tesal Brain Matrix in the UK, which is an adaptive trial. It's a new version of trials to be able to maximize what we can get from our study population. And using external control is another way of trying to get maximized the kind of data that we can access from our trials and studies. This was obviously initiated by the oncological clinical community, but interestingly, recently, only last month, this methodology was also published by the regulators and funders. So FDA published this paper last month, looking at the value of using external controls. So how did we choose our external controls then? So this was done through an independent expert firm, so nothing to do with the sponsor itself. And what they did, they looked at the range of contemporaneous trials who were matched with our trial based on 14 different criteria. And looking at these, they managed to find five trials based on a new diagnosis, glioblastoma, and 10 based on recurrent glioblastomas. And what they did then was to use the control arms from these trials to then compare with our study cohort who had received DCVax. There was a really exhaustive statistical analysis, and again on the slide you can see the various measures that were taken in order to ensure these cohorts of controls were appropriate for comparisons, and I'm happy to answer questions on this later. So these are essentially the 5 comparative trials on the top for the new onset glioblastoma, and 10 comparator trials for the recurrent on the bottom. And you can see most of these trials are very well known in the neuro-oncology community. I'd just like to take your attention to the top figure, looking at the new onset. And if you look, there are 5 different trials looking at 5 different treatments. If you look at the median overall survival, they're essentially all much the same, pretty much 16 months plus or minus 1 month. it is as if, regardless of what you throw at this nasty tumor, the outcome doesn't seem to change very much so far. So statistical analysis plan, therefore, for our primary endpoint, overall survival in newly diagnosed glioblastoma. So we compared 232 patients who had received DCVax versus 1,366 external controls. And the secondary endpoint, therefore, overall survival in recurrent glioblastoma, comparing those 64 patients which had crossed over with 640 external controls. And again, this statistical analysis plan was made well before unblinding of the study, and it was approved by the regulators. What did this all show? Top-line results. I'm glad to let you know that, excited to let you know that, privileged to let you know that the primary endpoint was met with significance. Secondary endpoint was also met with significance. And what is very interesting is how safe this treatment is. So in well over 2,000 DCVax injections, we saw only 5 significant adverse events that could possibly be related to DCVax. No autoimmune reactions, no cytokine storms, which were original concerns with using this form of immunotherapy. So let's look at the results in more details. First, new glioblastoma. So with our study, with the DCVax study, we found that the median overall survival was improved to 19.3 months from randomization compared to 16.5 months in the control patients. So almost 3 months added survival advantage. This was significantly more significant, increasing to 9 months when we look at the methylated cohort of patients. You know, I'm increasingly beginning to think that patients who have methylated, MGMT methylated form of glioblastoma are just a better prognostic group because, you know, they seem to respond to all sorts of treatments better. And this seems to be exactly the same when you throw the immunotherapy at them. So 9 months survival advantage, highly significant in this cohort of patients. There's a very interesting survival tail. So a cohort of patients seem to do particularly with DCVax who have glioblastoma. So at 5 years, more than twice survival if you receive DCVax versus otherwise. Also, very, very interestingly, there seems to be a survival advantage in those groups of patients who were felt traditionally to be in a poorer prognostic group, such as older patients. And I'll come back to that and elaborate very shortly. So let's look at the overall survival with the Kaplan-Meier's curve. We can see the improvement there, 19.3 versus 16.5. And again, you can see the survival tail, the longer survival tail that seems to increase over time. And if you look at this in more details, you can see at 36 months, 48 months, and 60 months, you know, that difference becomes more with the control group. And as I said, once you get to 5 years, it's more than twice more likely that you're going to be alive if you receive DCVax. It's very interesting. We had a primary initial look at the long-term survivors, and what we found was that clearly the long-term survivors do seem to have one of most of the already known better prognostic factors. So they have got better performance status, they are younger, they have had more complete resection, they have got methylated MGMT. But these factors are not sufficient to explain what's going on there, because we also have patients who seem to do very, very well, long-term survivors, who don't have these well-known characteristics. So I had a meeting yesterday with the Northwest Bio, and I've got a plan to look at these longer survivors in much more detail. So watch the space. There's a lot more to come on this, and I think it will teach us a lot about the biology of this nasty condition. Now let me show you some more interesting data. So I mentioned that, you know, DCVax seems to be even more beneficial for those patients traditionally considered to be in worse prognostic cohort. So as you know, we traditionally think that patients who are older, so over 65 or 70, tend to be doing much worse with glioblastoma. And I know centers out there who may not offer these patients the most comprehensive form of treatment. Very interestingly, when we look at our data, so we divide the patients over 65 on the left and under 65 on the right. And obviously you can see both cohorts, the ones who had DCVax did significantly better. P-values are there for you to see. But in the older age group, as you can see, the impact seems to be greater. And we begin to see those long-term survivors in the older patient groups, just as we do in the younger patients. So that is highly unusual for any treatment. Similarly, if you look at the residual disease, so on the left-hand side, we got patients who had a significant residual versus the ones who had minimal residual. And again, of course, as a surgeon, my aim is always to remove as much of a tumor as possible, and remains to date that surgery has a major role in these patients, despite what I said at the beginning, saying that glioblastoma is not a purely surgical disease. But surgery is still very important, so I'm not going to be out of job quite yet as a surgeon. But, life, as I said, we live in a real world, and life is not always perfect. And there are many patients in whom we are not able to do radical surgery, and there may be significant residual left behind. And again, very interestingly, these patients, again, you see on the left-hand side, significantly benefit from DCVax. And again, we still see that long-term survivals with these patients. So it brings in new hope for cohorts of patients traditionally thought to be in the worst prognostic groups. And no surprises when it comes to MGMT methylation, as I've already mentioned, very significant impact on these patients. But I genuinely think that MGMT methylated are a different, if you like, subgroup of patients with glioblastoma. They generally have better prognostic values, and this is what we see. They seem to do better with all sorts of treatments, and this is very much emphasized here with DCVax. How about the recurrent glioblastoma patients? Again, significant improvement in overall survival. So median overall survival improved 13.2 months versus 7.8 months. 6 months in survival advantage, very unusual for any other treatment. We've really not seen this kind of results elsewhere before. And again, we do see this survival tail, at 30 months, more than twice more survivors in patients with recurrent glioblastoma who had DCVax versus the control group. And again, this is reflected in the Kaplan-Meier curve. You see that improvement, very clear gap between the two cohorts, control groups versus DCVax groups. And again, the long-term survival tail is there for you to see. And this essentially summarizes the same thing, as you can see, as we move over from 6 months to 12 months to 18 months, eventually 30 months, that gap increases between the control arm and also DCVax. So let me summarize this data for you. So this is really the first phase 3 trial to show significant benefit from a systemic treatment in 17 years, and the impact on that, on the median overall survival in glioblastoma, new onset glioblastoma, is clearly seen there. For the patient with recurrent glioblastoma, first really study to show benefit in over 27 years. Really, really highly significant. Very, very exciting. And really one of the first studies, if not the only, to show this effect on the long survivors, 5-year survivors or more, which is very, very unusual for glioblastoma patients, and really opening new avenues of therapy for those cohorts of patients traditionally thought to be in the worst prognostic group. So really good news for that particular group of patients. But there's much more to come. So future horizon opportunities are immense. So for example, glioblastoma is a complex disease, but there are other new and novel treatments are coming along. I already mentioned tumor treating fields. So I think DCVax, by its nature, straightforward, easily deliverable treatment, can have the potential to be combined with a whole range of different treatments. And I think that's a really exciting area to focus on. In the surgical world, there is an increasing tendency now to reoperate on patients with recurrent glioblastoma. That wasn't the case 10, 15 years ago. But nowadays, we are a lot more proactive, and we do a lot more repeat surgery. Now, the data I showed you on the crossover patient for recurrent glioblastoma, you saw the impact on the DCVax group. But bear in mind, in that cohort of patients, DCVax was made based on the tumor at first presentation, not at recurrence. And we know that recurrent tumor is going to be genetically different from the first presentation. So imagine what would be the impact of DCVax if that vaccine was produced based on the tumor resected at recurrence. And I really think that is a really good study to come, and I'm going to be pressing Northwest Bio for sure to look at doing a study like that, recurrent glioblastoma reoperated using tumor to make the DCVax at recurrence. It is a highly safe treatment, and therefore it's much more easily deliverable than many other treatments out there for patients with glioblastoma. Could be given in the community settings even. Very good safety profile. And guess what? The learning from DCVax for glioblastoma, there's no reason why we cannot translate that to other solid tumors. I haven't personally treated any other type of solid tumors with DCVax, but technology is out there. And again, there's opportunity to look at treating other tumor types with this technology. I'm going to end here by acknowledging, there are many people to acknowledge. First and foremost, our patients and their families. Of course, without their help, none of this would have been possible. Everything that we do is for our patients, but clearly their participation in this trial is what made the whole thing possible. So thank you. I'd like to thank Professor Linda Liao from UCLA, the American chief investigator of the trial. Her help throughout the years and the support has been immense. I'd like to thank all the investigators. You saw this is a truly multi-center study across 4 continents. So all the investigators and sub-investigators, thank you very much for actively recruiting to this trial. Of course, the trial steering committee, thank you for your monitoring and vigilance throughout. And my wonderful team at King's, I'm incredibly lucky to work in what I consider as one of the best hospitals in the world, King's College Hospital, a real hospital for real people. Amazing place, the Department of Neurosurgery, highly supportive environment, and my own Neuro-Oncology team there. Thank you for all your patience and also for accompanying me throughout this journey. And of course, last but not least, Northwest Bio for sponsoring this trial. Of course, without their help, this would not have been possible. Thank you very much.